Now it's with great pleasure to introduce another member of our IBD Horizons board, Dr. Ghassan Wahbeh. He's a professor of gastroenterology and comes from Seattle University of Washington Children's Hospital. He's a good friend of mine. And Dr. Wahbeh, please join us on discussing cannabis and alternative therapies in IBD, the good, the bad, and the ugly. Welcome.
Thank you so much. Thank you, Dr. Afzali, for the kind introduction, and congratulations on the opening of the wonderful IBD Center. I'm sure everybody's looking forward to this talk, the most exciting talk of the whole symposium. Thank you for assigning this to me, Dr. Lee, Dr. Afzali. So over the next 10 minutes, I'll go over a bit of what we know and maybe we don't know about cannabis in IBD. These are my disclosures. Talk about the background, some background about cannabis, whether it improves symptoms, number one. Number two, whether it improves inflammation. And then talk about safety, and then see where we could place it if we need to place it somewhere in our IBD management. So cannabis, the plant source cannabis, has over 500 compounds, and the most famous of which are the tetrahydrocannabinol and the cannabidiol. The THC part is what gives the high, and the CBD is what is rumored and commonly, in the media that is perpetrated to have some positive effects on the body in probably a million ways, if you look at the various websites. Now, we have an endocannabinoid system in our body, and the receptors, the CB1, CB2 R receptors, are present around nerve endings in the intestine, around the epithelium, and also are expressed on some of the immune cells. So there is some credence to the role of the endocannabinoid system in inflammation. And this is actually clearer in mouse IBD, mouse colitis models, where the CB1R and CB2R, the receptors are upregulated in states of inflammation. And stimulating those receptors could actually reduce the inflammation or even prevent the inflammation from starting in the mouse model. So the combined effect of THC and CBD has been shown to reduce inflammation, and this is probably one of the pieces of information that your patients might come to you and say, here's why I want you to prescribe cannabis for me. The state of legality of using cannabis has been quite variable. Now, I skipped Canada because it's all blue. Congratulations, Dr. Fagan. It's all blue as in it's approved for recreational use. And the states in green, Ohio being one of them, is where the use is okay for medical marijuana. But it's also decriminalized. So consumers of marijuana versus dealers or producers are exempt from prosecution. Now, this does not mean that on the federal level it is okay. And there's this schism between the federal law that keeps or has kept marijuana as a Schedule I substance. However, the state law seems to be the dominant factor here. Now, this may not mean a whole lot for your patients, but it means a lot for us as researchers. To be able to conduct a clinical trial with cannabis in the United States, you have to, number one, register the drug with an IND, and you have to register with the Drug Enforcement Agency, and you have to get medical grade cannabis, and there's only one source as of now, which is the University of Mississippi. And I'm not sure that allows for a lot of variation in that product. If you want to study different forms of cannabis, THC, CBD, you really have to have a wider variety of products to study. So you can see how prohibitive it's been to study cannabis in the United States. And unfortunately, most of the data that we have are coming from overseas. So what's it like for IBD patients? You know your patients are exposed to cannabis. At any point in time, one of your patients has tried cannabis, and chances are 50%. Active users with IBD, about 1 out of 6. And there is a overlap with tobacco smoking. There's also an association with current use of narcotic medications and using marijuana at the same time. So I think we're getting a signal here that patients are exposed to tobacco, are exposed to narcotics when they have some exposure to cannabis. Now, most forms of cannabis are inhaled. Some are obviously ingested, but the rising popular option here is vaping, and that becomes important in the next in a few slides here, as I will show you. But vaping is a so-called cooler form of getting a tobacco fix or cannabis. Another big difference is if you compare the potency of most cannabis products today, it is multifold stronger than what was available 10 or 20 years ago. We do have synthetic forms, and a simple example is dronabinol, which is used effectively in treating symptoms of lack of appetite, nausea, and to some degree pain in cancer patients and HIV/AIDS patients. So let's ask ourselves the first question. Does cannabis improve symptoms? Yes, obviously, not a question. And in multiple studies, you can see that most patients do feel better when they use cannabis, and that's in terms of reducing pain, increasing the appetite, and to some extent reducing diarrhea. And this is not unexpected. If you ask patients about their perception about using cannabis versus steroids, the majority would love to try cannabis before steroids. It's a natural product, right? And we've done a good job, I think, scaring our patients away from steroids, but they're not going to other better medications. They're going to cannabis. And of course, a sizable number of patients report their impression of cannabis as a lot safer and a lot more effective than corticosteroids. Now, the ultimate question for us, and you'll hear more about this later today when we hear the treat to target talk, it's not enough to reduce symptoms. We need to look at reducing inflammation. This is where the majority of our outcomes are affected by. Now, again, studies that come from overseas, and this group by Naftali and colleagues have published several papers on use of cannabis in different forms, inhaled and ingested. This one looked at 21 patients, so small numbers, with Crohn's disease who have been unresponsive to steroids, immune modulator, and anti-TNF, and they're randomized to either have inhaled cannabis with some THC or placebo, which are cannabis flowers without the THC. And this was for 8 weeks. And as you can see, there was no difference in terms of objective measures that point to reduction of inflammation, CRP, the hemoglobin, no difference between the active group and the placebo group. This is the largest prospective data series that we have from the UK of about 60 patients, and this lasted about 12 weeks. This was for patients with colitis now, who are with moderate to moderate colitis, who are resistant to mesalamines. And the study looked at the Mayo score, including endoscopic score, for inclusion and for primary outcome. Now, this was oral CBD containing drug versus placebo. And it was difficult to take the THC. Remember, the THC is what gives the high. It was difficult to really purify that CBD product and keep it without THC. So with some THC involved in the drug, the active drug group. The results failed to meet their primary endpoint, and you see, although the endoscopic improvement was numerically higher, it was not statistically significant, and clinical remission was not different between the active CBD group and the placebo group. What's interesting, again, we've seen this before, what's interesting is that if you break it down to the partial Mayo score that looks at a number of stools, bleeding, and the physician global assessment, there was a statistically significant difference in the patient group that received CBD. However, in this very paper, when you look at calprotectin and whether calprotectin improved, there was no significant improvement. So again, we keep getting the same signal that there is some symptomatic improvement. However, there's no objective reduction of inflammation. In this study, again, this was a randomized, double-blind, placebo-controlled study. It was quite difficult to maintain blinding, number one, because of the THC component that could not be purified. And patients struggled often being a little dizzy and a little sleepy. And this could have affected adherence. So the study has quite a few limitations there, but nevertheless, one of the best designed studies on cannabis. So let's ask the question of safety. Is cannabis safe to use in IBD? Well, if you look at the studies and just look at the tables that say how many patients had adverse events, we're hitting a high 86% here. And the most common reported adverse event was feeling high, which may not be considered an adverse event by your patients. Easy laughing, increased awareness, that's probably what your panelists looked like and will look like for the rest of the day. Paranoia, some of my best friends are paranoid. So those side effects were reported mostly as very mild. And when patients were asked if they actually needed to feel high to feel better, the answer was really only 20% of patients needed to feel high to have that positive effect. In the same paper, which looked at over 300 patient surveys, a prolonged use of cannabis, prolonged being over 6 months, was associated with the need for surgery, similar to smoking. And this doesn't mean causality necessarily, but it is an association. And I think we have to ask ourselves time and again, why are patients using cannabis for 6 months for their IBD? And that might be the question to ask. But nevertheless, there is an association between the consumption of cannabis and surgery. A new thing that popped up last fall, which is called EVALI. EVALI stands for e-cigarette vaping associated lung injury. And it peaked back in August and September of 2019 with this national outbreak of well over 2,000 hospitalizations attributed to this exposure and 64 deaths. And these were young individuals. The good news is that the incidence is decreasing. So the research conducted on patients with this severe lung inflammation syndrome compared to controls, it turns out that the patients who suffered from this had significant amounts of vitamin E acetate on their bronchoalveolar lavage. And it turns out that vitamin E acetate was not used for tobacco vaping. It was used for specifically THC vaping as a thickener. And the controls who were vaping tobacco and not THC, not having symptoms, did not have the vitamin E acetate trace in their BAL. And of course, because of the fact that these products are not regulated, we don't know what other chemicals could have contributed to it. But clearly, vaping THC products was a very, very likely suspicious cause of this severe syndrome with reported fatalities. The silver lining out of this is that the control group was actually OSU students. So thank you, Ohio State. This is wonderful. Thank you, Dr. Afzali. So we should ask ourselves the question of should cannabis be used in IBD management? Well, the answer is no. But we should certainly ask our patients about using cannabis for, and whatever reason they are using cannabis for, and ask specifically about vaping. In my clinic, if I ask about smoking, that's not good enough. Again, most younger individuals are looking at vaping and not smoking. Smoking is old school. And time and again, we should explore the symptoms that drive our patients to use cannabis. We should also provide a different plan for managing whatever that symptom is. If it's pain, we should address the pain. If it's a sleep issue, we should address the sleep issue. Depression, anxiety, which we know are quite common in IBD, then we should address these issues specifically. And we should also outline the goals of therapy in IBD, and that's going to be discussed later today, and educate our patients about the safety of these novel products and use the example of the EVALI syndrome that has led to fatalities. We should also equally recognize that our patients may want to use cannabis recreationally, whether we like it or not. And that for the majority of these so-called adverse events, they're really mild, and patients may trade a better night's sleep for that occasional sense of paranoia or dry mouth. So we should recognize too that patients are using it recreationally without necessarily wanting to treat anything related to their IBD. So in summary, we know that there's a mechanistic rationale for cannabis effect in IBD that is worth probably studying in the future. We know that IBD symptoms could improve with cannabis use, and some patients can reduce their steroid use, but look at them both as Band-Aids that the patients are using. We still have no good evidence to support that endoscopic improvement exists with cannabis, so mucosal healing is not an expected effect of cannabis. And that we have to look at the safety of what our patients are consuming and the unknowns about the new products, and keep exploring, again, reasons why patients consume cannabis and try to help them in more targeted therapies. And certainly we need to maybe grow up with these incredible limitations at the federal level that really cap our ability to study cannabis in any meaningful way. So to answer the questions, the cannabis as an alternative therapy in IBD, is it good? It helps with symptoms. Is it bad? It doesn't help with mucosal healing. But is it really ugly? That's not what I'm hearing. Thank you.